Is your Hi, this is Dr. Bob Dannenhoffer. I'm the Public Health Officer from Douglas County, and we're another of our Facebook Live. We took a break last Friday, but we expect to be here twice a week coming up. Again, this is your chance to ask questions. You can put them in the chat section. If you have longer questions, and we have a couple today, you can put them in the mailbox called Facebook Questions at DouglasPublicHealthNetwork.org, and we look at those and try and answer those as best we can. As always, we start out with the world situation. We've got a bunch of little interesting stuff today, and we'll go through that as we get it. But again, we'll talk about the situation. Well, the situation in the world is that the number of cases is declining, although there continue to be some real hotspots around the world. The big hotspots we're seeing now, we have 500,000 cases per day. That's a lot of cases per day still. We as a world don't have this under control, and we're still seeing 10,000 deaths per day. And so this is still a pretty active pandemic. Now, I know we've been through a lot, and at this point we consider we're pretty much done, but I would tell you if we had another disease, Ebola, a pandemic flu, or something new that was causing 10,000 deaths a day, we would be so frightened. But I think we've gotten a little bit complacent, recognizing that the amount of disease in the United States is really going down. Still seeing a lot of disease in South America. So South America continues to be really hot. India, Bahrain, which is a little tiny country on the Persian Gulf, the Maldives and the Seychelles all have really high levels of disease. And we're starting to see increases in places that previously had done a really good job with this and hadn't had a lot of cases, like Malaysia, Vietnam, and Taiwan. And all of them have started to see some new variants, and these new variants are breaking through the public health measures that they had. In addition, they've seen so few cases over the last few months that they stopped testing and sort of lost a little bit of compliance, and they're starting to see cases. Now, the numbers are still very small in those areas, but the concern is that those places that have done such a good job so far now see a lot of cases with these variants. We really need to be concerned. What my scariest statistic over the last week is that the Seychelles, which are tiny little islands in the Indian Ocean, Bahrain, again on the Persian Gulf, the Maldives, an island chain off of India, and Uruguay, all have very good immunization rates. So you think those places should be really protected from the disease, and yet they're the places that have the most disease in the world, suggesting that high vaccine rates work, but when you get the variants, they don't work nearly as well. When in the U.S., the great news of the cases continue to decline. We're averaging about 17,000 cases per day. So you remember there was a time where the U.S. accounted for a quarter or even as much as a third of the world's cases. We now account for only 8% of the world's cases, so that's great. But we're still having 17,000 cases a day. I can remember back to SARS, remember back to Ebola. We didn't even have 1,700 cases, much less 17,000 cases over the entire course. So again, we've gotten a little bit complacent with this high number of cases and still about 400 deaths. Again, in the U.S., there are no real hotspots. Colorado, northern Missouri, for whatever reason, and New Mexico do have little hotspots along the way. But in general, the U.S. is doing a good job and is down to about 5 cases per 100,000 per day. Now, Oregon is a little higher than that. We're at 9 cases per 100,000 per day, but we're declining. And the hotspots, you remember we've been talking about Klamath and Deschutes for several weeks now that have been really hot, and now they've bled over to Douglas County, and Douglas County has been relatively high. We're at 17 cases per 100,000 per day, one of our highest levels ever. So we're at a high level, and especially what we're seeing is high hospitalization rates, especially among the young. And so again, early on, the hospitalizations were mostly in people who are quite a bit older than me, but now what we're seeing is hospitalizations and deaths in people who are considerably younger than me, and that's a concern. And again, we think that's because of the variants. Our latest variant analysis showed that both the P1 and the B117 are here in Douglas County. So again, let me go to the questions here, and then we'll see what we get. So someone said, can we get more info on the positive cases that were vaccinated? So over the last 3 weeks, going through last Thursday, we had 335 cases. That's a lot in 3 weeks. So 335 cases over the last 3 weeks. 329 had not received any vaccine at all. So 329 were not vaccinated. So again, 329 out of 335. So an overwhelming number were not vaccinated. We had 6 cases of people who were vaccinated. None were seriously ill. None were hospitalized. Some, we think, were just that the vaccine doesn't work 100% of the time, but works most of the time. And some were related to, we think, to a variant, especially the P1. So that's the concern. We know that the P1 especially, and the 617, which is from India, probably the vaccine does not work as well. And so the goal would be to get the disease down before those variants become more populous. So Pam says, why the sudden jump in deaths? So remember, deaths follow cases by 2 or 3 weeks. And remember, 2 or 3 weeks ago was when we had our really high spike in cases, and that's why we see the deaths. So what happens is in the first week of the disease, people feel terrible and sick and whatever, but they're usually not really ill. The average day for getting hospitalized on the 7th or 8th day of the illness, and the peak for deaths occurs at about 2 weeks after. And so the sudden jump in deaths is related to the spike in cases we've had over the last 2 or 3 weeks. I would not be surprised if we have another few deaths over the next several days. And these deaths are worrisome. One person was 54. I don't think anybody at 54 is thinking, well, it's about time for me to go. No, at 54, people are expecting another 30 years of healthy life. So these are really deaths cut short. So Michael asks a complicated question. So we've heard that vaccination numbers will not include anyone under the age of 12. Why do we count all cases regardless of age in our case counts, but not count them among the vaccinated to help us reach the threshold towards herd immunity? So we don't count any of the cases in getting us to herd immunity. So when we were looking at herd immunity, presumably people who were previously infected might have some protection. But in the numbers of the vaccinated, we just look at the number of people who actually got the vaccine. Now, how do the people who are previously infected, how do they count? They probably count some, because we know that people who are previously infected are less likely to get it. But I will tell you that varies all over the place. Some people suggest their protection as high as 90%. Others suggest their protection as low as 70%. So it's hard to know. But a decision, you had to make a decision. Do you count the people with cases, or do you just count the people who are vaccinated? And the decision is made just to count the people who are vaccinated. And since we're just counting the people who are vaccinated and people under the age of 12 can't get vaccinated, that's why we're not counting the cases. This has spiked a lot of controversy. Like, oh, everybody's had it already, so we don't have to really worry about vaccine. It's not true. I mean, in Douglas County, there are a couple of ways to check. One is you could check the antibody levels, probably less than 6%. You could check our case counts, about 3%, and say we've even missed half of them, and we might have missed half the cases. That, again, is only about 6%. And even if you take our current vaccination numbers, which are about 52.5%, and add those people, it still doesn't get us up to that 80% we need. And if you say, well, let's just have people get the disease, to get the extra 10 or 12,000 people we need to do, you'd have to have 30 cases a day, which would be a lot of cases for 1,000 days. To get to another 10,000 for 300 days, that's a whole year of having those cases. And when you had those cases, some of those people, for whatever reason, would get really sick, meant you would be hospitalized, and some would die. So I don't think that waiting for natural infection to be the cure is going to make it work. Another question is, when we report the daily out-of-area hospitalization, what does that mean? Well, it means that they're hospitalized outside of Douglas County. Most of those are at Riverbend. Some are at OHSU. We have an occasional person at St. Charles or the hospital down in Medford. Again, when people get hospitalized, they get hospitalized where they are. So most of these people start out at Mercy. Some of them then get transferred either up to Riverbend or OHSU because they need a higher level of care than we can provide here. Or people live on the on the borders of our county, for example, you live far south and then get sick, you may go down to Grants Pass. And then some of the people are traveling when they get it. But these have all been in Oregon over the last several weeks. So they're mostly Mercy, but then some are Riverbend, some are OHSU, and a smattering in those other places. Another question is, we're hearing from those that a lot of the kids are getting this at school or school related. So when we see cases in younger kids, and again we'll take high school age kids, so 18 and below, there are a couple of things that we see. One is, very frequently they get it from one of their parents who is not vaccinated and gets the disease, and then they give it to the younger kids. So that's the most common way that kids get infected. Mom or dad gets infected at work, they bring it home, they spread it to everybody at home. So that's the most common way. Now, if kids are in school and have gone to school during the contagious period, that then leads to some quarantine of the kids they were around at school. We're also seeing after-school related things like sleepovers. So sleepovers, are a real part of childhood. Kids come in, they sleep over. Can't imagine how many sleepovers we had at our house when the kids were younger. And typically you have sleepovers with kids who the kids go to school with. So they go to school, they have friends. They say, hey, this weekend you want to come over to the house and sleep over? Sure. And that's where we're seeing it. When we look, you don't get a receipt when you get the disease. But when we look at the timing and whatever, it's possible that the kids who went to school with each other on Thursday and Friday had a sleepover Friday night and then get sick on Tuesday or Wednesday of the next week. It's possible they got it at school, but we think it's more likely that they got it at the sleepover, because at the sleepover they're likely not wearing masks. At the sleepover they're together and close together for a long period of time, whereas at school they're nicely separated in that. We have seen a little bit of spread at school, and the little bit of spread at school we usually see is from teachers to students. We've had a couple of times where that's been reported elsewhere, that the most common is teacher to student. We've seen occasionally with student to student, and again, most of these students know each other outside of school, so it's a little hard to know if they transmitted at school, they transmitted on the bus on the way there, or at the bus stop, or at some other time. And then we've also seen some spread among sports teams. And again, sports teams do have a tendency to be close in the locker room. They do tend to be close in huddles. They do tend to be close in stuff that they do before and after sports. Because so much of when we talk about the good things of high school sports, it's not just what happens on the field. It's the teamwork and the camaraderie that you build up before the sports and after the sports, or you go out for celebrations after the sports. So Denise says, what is the percentage of efficacy for the first shot of Pfizer in 12 to 15-year-olds? Well, there were no cases after the first or second shots in that, so it would be 100%, but the number of cases in between the first and second shots was very small. Now remember, these were done at a time when the disease was waning, and so there were not that many cases, and so it's going to be hard to know the efficiency. And so the press has a tendency to give the number that they gave. Like, these vaccines were 100% protective against death. Well, it's because there were, in the vaccine group, there were like 19 cases of the disease, none of whom died. So, yeah, it is 100% in that group, but if you had 190, you still might have had 3 or 4 deaths. So I worry when people talk about statistics without talking about confidence intervals, because the confidence intervals on those would be something like 85 to 100%, and that's what I like to say when I like to say above 90% efficacy for the vaccine, because it really seems in Douglas County that's above. Now, I could cook the numbers and make it look 98% effective, but again, I don't want to oversell this, but the vaccines are at least 90% effective. I mean, that is so effective. People talk about using masks. At best, masks are a few percent. And back at a time when all we had was distancing, masks, and lockdowns, it made sense to do all of those. But now that we've got stuff which is over 90% effective, it'd be so much better for people to get the vaccine than for some people to continue to wear masks. Okay, well, let me go through some of this. Well, one of the things about the variants that has been so confusing for many people is that the variants have been described in so many different ways. So, for example, some have been described by the mutation. So this D614G that I've talked about is a mutation in the 614th amino acid, or the E484K, which is the EEK, is a mutation. Some are lineage lines, like the B.1.1.7 is a lineage. And then some people describe these by the place they first showed up, like the B117 first showed up in the UK and was the UK variant. So the World Health Organization said, oh, this is getting very confusing, and it indeed is getting very confusing. So what they decided was to name these after the Greek alphabet, alpha, beta, gamma, delta, epsilon, and to name them in that way. So it's going to be confusing for a while because the B117, which we've also called the UK variant, is now called the alpha variant. And that B117, first seen in the UK, now called the alpha variant, is more transmissible, but likely not more serious and likely well protected for by the vaccine. That variant, the B117, first seen in the UK, now called the alpha, is the predominant variant on the east coast of the United States, was the predominant variant in Europe, especially in the UK, but that has changed. The second one is the B1351, which was first seen in South Africa, also called the South African variant. It's now called beta. So alpha is the B117, beta is the 351. That one we worry about because that one seems to be less well protected for vaccines and maybe a little bit more contagious. The third one is what we call the P1, which other people call the Brazilian variant, is now called gamma. And that one we really worry about because that one is more transmissible and seems to be immunoevasive, meaning that people were previously infected, previously infected with a previous strain, now seem to be able to get the P1 Brazil gamma variant. And so it's more transmissible and whatever, and we worry about that. We have an outbreak here in Oregon of a P1 that's now over 20 cases, including a bunch in Douglas County, and that really spread quickly and spread in places where people use pretty good precautions. So we worry about one. So the P1 is Brazil, also now called gamma. The last one that we're going to go through, they go through down through epsilon and whatever, but the other big one is the 617, which is from India. That's called now the Delta variant. That is very worrisome because it does seem to be more transmissible and it may evade the vaccine some. However, the vaccine is still pretty effective against all of those. Most effective against the ancestral strains, which don't have a Greek letter. Very effective against alpha, somewhat effective against beta, gamma, and delta. So again, we'll go through this a lot because it took me about an hour to figure this out, but we'll go ahead and do that later. Another question came up is what's going on with the Wuhan Lab and whatever. So there's been a lot of controversy about that. So again, I think everybody thinks that this originated in a bat, probably in China. But the question is how did it get from the bats to the people? And we don't really know. And I think we don't. I mean, the WHO suggests that it went from a bat to an intermediate animal and then to the wet market. It's possible. I think the other possibility is it went from the bat or the bat collectors, some of whom work in Wuhan. So this Wuhan lab has been working on coronaviruses for a long time, as they should, because coronaviruses cause SARS, they cause MERS, and now they cause COVID. So learning more about these would work. So there's a benign explanation that a bat handler or somebody got it and then spread it among their friends and neighbors. They didn't know what it was, and then it spread. I think that's possible. It's possible that it actually was in the lab, that their containment in the lab broke down. I mean, this happens too. And that it broke down in the lab, infected somebody, they spread it to people, and the community got out. I think that's possible. People talk about the possibility that they've been working on this to make this a contagious bioweapon. I think that's less likely. The timing isn't quite right. I mean, you would have had to do incredible work in a very short period of time and leave no fingerprint if this was a bioweapon. The Chinese suggest it's an American bioweapon. I don't think that's very likely either. So I think we really should try and figure out what it is, because if this is a loss of containment, then I think we really have to think about these high-level labs, because some of these high-level labs work with really dangerous stuff, Ebola, SARS, smallpox, and whatever else. And if these labs are doing something wrong and letting it spread to their workers so that their workers can get sick and bring it home, we need to know about that. And we need to have a very high level of scrutiny for people who work at labs, not just in China, but everywhere. So if you're working in one of these high bio-level labs and anybody gets sick, the janitor or anybody gets sick at one of these places, I think you have to really regard it as a real emergency, because you could imagine you're just the guy who delivers stuff, but there's some trouble with the ventilation system and you're getting exposed to it. So I think we need to know a little bit more about what goes on, and I really applaud the last movements to see. Now, the problem with this is that I don't think anybody would be honest. I'm not sure that there's any country in the world that if they had a break in their biosecurity lab 4 is going to come out and say, yeah, we goofed, we weren't following the rules and people got sick. So I'm not sure we're ever going to figure it out, but we really should. Okay, a couple more things. We're always finding out new things about COVID. One of the new ones is a thing called COVID tongue. So we now have COVID arm that you get after the vaccine, COVID toes, which looks like frostbite of the toes. We've heard about the loss of sense of smell and taste. And now there are some people, apparently when they get COVID, they get quite a swelling of the tongue, which looks gross. I mean, big tongues don't look that great. And these pictures really look terrible. It's rare, so it's not something we should expect. But one of the things that happens when you have this many cases, you find about rare and rarer and rarer side effects. One of the things that was in the media this week is about the vaccine efficiency. And again, our numbers look really good. Our numbers look like it's well over 90% effective in preventing symptomatic disease. Really, there's nothing else you do that's 90% effective. Mask, distancing, all those things are somewhat effective, but not nearly as effective as these vaccines. I'll tell you, nobody could have expected that. Back in the fall, I'd written some notes about the vaccine, and when I said if we get a 50% effective vaccine, we should be really happy. I mean, to have a vaccine that's in the 80s or 90s is really amazing. So a couple other things. One is a study from Thailand. So Thailand is going through its own little spurt here. Early on, it was found that dogs could spot a particular odor in people who had COVID, and it was sort of an interesting story, and then nothing came of it. But actually, much more research in Thailand suggests that dogs can be trained to find the odor of COVID. It's a little hard for humans to understand how somebody with COVID would smell different. But there are a bunch of diseases where dogs with this incredibly active nose can spot the difference. So melanoma, there's a dog that can spot the smell of melanoma. There are dogs who can spot the smell of other diseases. And it's hard to imagine when humans have such miserable smell, what the life must be like for dogs. So we've got about 6 million olfactory things, and we can smell some stuff. But they have 300 million, and well-trained dogs can really find all of those 300 million so that they can spot the odor of somebody running through the woods and find out where they were. They can find a cadaver which is buried 6 feet under. I wonder what it would be like. There are only two strong smells that I can imagine. One is the smell of skunk, and we've all smelled that. And you can smell that from miles away. And then the smell of asparagus after somebody eats it and then peas. And you can smell that. Imagine if instead of just those 2 smells that you could smell really strongly, there were 1,000 smells like that you could smell really strongly. It'd be a totally different world, I think, if instead of just those 2 smells, there were 1,000 smells. And then you could say, well, yeah, Joe smells like a mixture of of this and that, and then figure it out. So that's truly remarkable. What they found with this. Another thing that they found, which is just fascinating, is the ability to taste bitter. So when I think of bitter, we don't eat very many bitter things, but in Japan there are bitter foods. There's something called bitter melon, which is a big deal in Japan, or people who drink gin and tonics. The tonic water has clearly got a bitter taste to it. And there are some people apparently who cannot taste bitter, some people who can really taste bitter, and then there's people in between. And what they found is that those people who could taste bitter were much less likely to get COVID and much less likely to get really sick. And apparently the bitter receptors in the mouth are somewhat related to the way your nose handles germs. So that was a very interesting study that unless there's something really crazy with the people who wrote it, really looks like that can help to distinguish. And it helped to distinguish by a lot. So in the past, people have worried about like blood type, and that may be a 5 or 10% difference, or ethnic things might be 5 or 10% difference. This was like a tenfold difference. So it was really pretty amazing. And then the last thing, which is weird, is that the people at MIT did audio recordings of people with cough. And I heard these, and they took somebody who had a cough from something else, was COVID negative. They had the cough from somebody who was COVID positive and was coughing. And then they had the recording of somebody who was asymptomatic but was asked to cough. They all sounded the same to me. And I listened again and again. They all sound the same to me. But apparently, computers are really good enough that they can tell the difference between these coughs, and with over 90% accuracy, identify whether somebody has COVID or not. This is really amazing that dogs can do it, MIT computers can do it, and whether you can taste bitter tastes have something to do with it. So there's all kinds of weird stuff going on out there, and I think it's just amazing stuff we'll learn from this. I'm sure my grandkids or my grandkids' kids will look back and say, oh, they were just so, can you believe how old-fashioned they were in 2020, that they didn't have our specific thing where you don't even have to go to the doctor anymore, just cough, and we can look on the computers, oh, that's fine, that's just allergies, don't worry about it, or they cough, say, oh, that's COVID, you need to do something else. So truly remarkable about that. Let's see, I'm having a little computer trouble here. Let me see if I can find some more questions. All right, well, I'm offline here, so I don't have any more questions. So if you want to bring them in written, I'll take a look at them and see. One of the other things that the question was that we've had in the past is, can you mix the vaccines? For example, can you get a Pfizer and later get a J&J? Can you get a Moderna and then a booster with a Pfizer? They actually are doing, and I said I didn't know because they hadn't done the studies. They're doing the studies now, and at least the preliminary results suggest you can. And there was one preliminary result suggests that not only can you, and yes, Vanessa, if you could text them to me, that would be great, and that actually it may be more effective if you mix vaccines than stay with that. Again, the data on that is really, really early, so I don't want people to go ahead and switch what they're doing. But the good news is we may get there. And so that would then be helpful, perhaps, when we're doing boosters to get it. All right. A question. At your clinics, do you have an ambulance just in case? Yes. And they are, for those people who are old, will remember there was a commercial about the Maytag repairman. And the Maytag repairman was just sat around all day with nothing to do because Maytag appliances were that they were so sturdy that they never broke down, so the Maytag repairmen. So similarly, our ambulance people are like the Maytag repairmen. They sit and wait for these, and they really never needed to break out their emergency kit. We did have one person who felt faint and actually had a little fainting episode after getting a J&J vaccine. And we have had a couple of people who feel itchy afterwards, but no one who's ever done anything. Another question is, are we going back to extreme? I do not know. They have changed so many times about the idea about what we do that I just don't know if we're going to go back to extreme or whether we're going to stay where we're at. So that is a concern. Someone says, do you have natural immunity after getting COVID, and how long does it last? I don't know how long it lasts. What we do know is that the immunity that you get after having a natural infection is pretty good, right? So what they've been able to do is, obviously New York City had a big surge in the spring, and then they could follow these people after, and most of these people didn't get it. So they had at least 80% protection from a future infection, which seemed to be pretty good. But how long does it last? We don't know. So the antibody levels after natural infection are very variable. They go anywhere from pretty high, most people in the mid-range, and some people in the low range. So we don't know how long this can last. We do know that the antibodies do tend to dwindle over time. But the thing we don't know is how good your T-cell response is. So your antibodies are proteins in the blood. You can measure those in the blood. If, for example, you measured my antibodies to measles, they would be very low, but I guarantee you I'm immune, because if my body saw the measles virus again, it would instruct the B cells to make more antibody. We don't know how well that works with COVID. We think that the immunity after COVID is very good for 3 months. Between 3 months and a year, it's still sort of question. So another question is, how many cases have we had in schools in the last few weeks? There are a lot of schools where there have been a case. So when there's a case in a school, we start looking and doing that. There have only been 3 that I know of where there's been a second case at school. Now, when there's a second case in school, it could be that the teacher who was positive gave it to the kid in the class who was positive. It's also possible that the teacher got it one place and the kid got it at different places, and they're in the same school, but they're not related. But we've seen some of those where there's instructors and then kids. So I think 3 of those. So what is required to go to Mexico? So all of these travel things change on a nearly daily basis. So people have been asking me about friends who want to go to Europe, or friends who want to go to Mexico, or friends who want to go other places. And really it changes so quickly that I would have you check with the CDC has an area for travel restrictions, and they can tell you typically what the places require. Now, if you're not vaccinated, I would be really concerned about travel. I would be really concerned about traveling because although we think airplanes themselves are very safe, we certainly know that people who get into the airports, all the crowding that's in airports and whatever, is a place they could spread. So specific for Mexico, I'd have you check, but I really encourage anybody who's looking to do international travel to get vaccinated. So for a high-risk kiddo under age 12, what precautions do you recommend? Well, there are 2 things we would recommend. One is I would recommend reasonable public health precautions. That means that if you're indoors in a crowded space with unvaccinated people, that you wear a mask. If you're outdoors in very crowded situations, not very many of those, that you use a mask, and that you avoid people who are sick. The other recommendation is to create a fortress of protection. So again, there are some people who can't get vaccinated for a reason. So a dear friend has had 2 anaphylactic reactions with other vaccines, and the recommendation was that they don't get any more vaccines. That's a very rare situation, but it's true. So the recommendation in that case would be to do what we call a fortress of protection. Everybody around them should be protected, should be immunized, so that the disease has less chance of getting them. Remember, the number 1 place this spreads is in families. So when I get a vaccine, it's not just to protect me, which is important, but it's to protect those in my family that either may not be able to get protected, like my granddaughter because she's only 4, or my or my mom, who may not get good protection because she's over 90. So the 2 recommendations for a kid under 12: Precautions I recommend, so indoor, when you're not around vaccinated people, to wear a mask. Social distancing, staying home from people who are sick. When you're outdoors in very crowded situations, don't happen very often, to wear a mask. And to have those people in the household around them who can get a vaccine to get a vaccine. Okay, well, we had a couple more things here. One is boosters. And so there's a lot of question about boosters, and boosters are always really a question. For whatever reason, they put me on airplane mode. Boosters. So the question is, are we going to need boosters? When are they coming, and what's going to happen? Well, again, there's three reasons you use boosters. One is you come up with a new kind of vaccine which is more effective, like the shingles vaccine. There's a new one which is much more effective than the previous one, and we recommend people get it. The second is if you have waning immunity, and it looks like the immunity on this is holding up for at least 9 or 10 months. Whether it falls after a year or so, we don't know, but we're gonna find out. And the third reason you would do it is if the virus changed enough that you'd need a new vaccine. So far, we haven't really seen that. Again, each of the variants seems to be pretty well protected by the vaccine, although I do worry about the beta one, which again is the South African 351, which seems to evade, not do as well with the vaccine, and the Delta, which is the one from India, 617, which also may evade the vaccine. So we might come up with a new vaccine. The problem is that if you came up with a booster for a new variant, it would take 6 months to get that all done and made up and figure out how to do that, and the variants change very quickly. So the B117 took over in the UK in 3 months. So even if you had figured that out then, it wouldn't come quick enough. And now the B117, which was the UK variant previously known as Alpha, is getting forced out by the Indian variant, again the Delta. And so, even if in February you decided you were going to do that, you didn't know about the 617 then. And so what I say, this is like playing whack-a-mole with really fast moles and really slow mallets. So that's it. So question, is there a correlation between diabetes and COVID? Well, yes, there is. So we know that diabetes is one of the underlying conditions which seem to be putting people really at high risk for COVID. And there's at least 3 or 4 reasons for this. One is that diabetes may come on all by itself, but it's frequently associated with obesity, which is another risk factor, with age, which is another risk factor. In addition, when you treat people with COVID, you're sometimes treating with steroids, like dexamethasone. And the issue with steroids then is that it further throws your diabetes out of control and just makes everything go worse. And the last is the question is, why are kids less affected, and why were people with high blood pressure or people who with other kind of things more likely to get sick? And this is the Bob Dannenhoffer theory. I've not seen this written anywhere or proven anywhere, but it seems that those people who have blood vessels which are worn down or not working as well seem to have more troubles. So babies, when you do autopsies, sadly, for other traumatic reasons, and look at their blood vessels are absolutely smooth and slick. They look like a newly paved highway. When you look at people who are 30 and 40, you start to see little potholes in there. Some people a lot more than others. And then when you look at 60-year-olds, they're starting to look a little ragged, and especially people with diabetes, people with high blood pressure, people with other conditions. Sometimes these look really very ragged, and then by the time you get to 80 or 90, everybody's got kind of raggedy-looking blood vessels. That almost exactly follows the mortality with COVID. So the mortality with COVID, almost everything that predicts a dinged-up vascular system predicts severe disease and death in COVID. Now, people with diabetes have really lots of vascular disease. So you probably know people have diabetes who wind up with amputations. And so amputations are a vascular disease, so the blood vessels don't work very well. Blood flow doesn't get to the feet, and then you wind up with amputation. So we know that the blood vessels, especially in people with diabetes, are really problematic. So another question is, what do you consider a very crowded situation? So an outdoor crowded situation would happen very rarely, but let's say you're going to a concert and there was a crowd of people at the ticket line trying to get in there where you could touch multiple people at one time. I think in an outdoor situation, if you did something like a rave where people are right on top of you, I would consider that a very crowded situation. Or, sometimes you go to one of these places and there's one bathroom and there's a line a mile long. Again, if people are all crowded in there, I would consider that to be a crowded situation. I can't think of an outdoor crowded situation I've been in the last 15 months, but I bring my mask just in case. All right, so the question is, what are the incentives for the county or the state to get more people vaccinated? Well, we don't get any more money for it. We probably would get some kudos, but we don't get any extra money for it. The county doesn't get any extra money for having people vaccinated. The vaccines themselves were all purchased by the federal government, so they're all free to the people who get them. When we do our events, we don't even collect insurance information or any money at all. Now, if you go to a clinic, they may collect your insurance information and charge your insurance or charge the government, but we at Public Health don't charge anybody, so we don't get any more money from getting more people vaccinated or not. For me, it's just the sadness. I mean, there's this young fellow who's been quite sick at Mercy, hope doing better today, but really a young fellow, young enough to be my son, and really sick in the ICU, and I just don't want to do that. So I heard a story today about one of these people who was very sick, and they say they're just so weak, they can only do a few minutes of speech therapy before they just totally tuckered out. Well, this person was big, strong, sort of athletic kind of guy before. And so that's a real worry when I hear about somebody who's that sick that can do it. We have another person in his early 40s who's so sick he can't go home from the hospital. I mean, he's on continuous oxygen and whatever, so really can't get sick. And that's what I want to prevent. I mean, I don't get it paid anymore if we get nobody vaccinated or everyone vaccinated. Yet, what we do get is we get the sense that I don't have to worry about this. I mean, there's a lot of other things I like to do. I'd like to take a vacation at some point. I'd like to go ahead and be able to safely visit my mom. But I think at this point, with the amount of disease we're seeing in Douglas County, there is still some risk. And my fondest goal is to have every senior, they've had 12 years of school and they're graduating, to have no seniors who are under quarantine so they can all go to graduation. And sadly, I think we're going to have at least a handful of seniors who've been exposed and are not going to be able to attend their graduation because of quarantine. And that's why we do this. There's no extra money in it for us. I wish there was, I'm not sure I wish there was, but it would be really, really, really nice if people would do it just because they want to protect those kids so they can go to graduation. It would be nice if people would do this because they don't want an older relative who doesn't develop good antibodies to get this. I would love people to get vaccinated so my friend who has had these severe allergic reactions who can't get the vaccine can get protected. So that's what we do. That's why we do this. Okay, so let's see if there are any more questions here. Had a few more things. So one of the things that's concerning is these 4 countries that have really high vaccine rates. So the Seychelles, these little places in the Indian Ocean, the Maldives, and Bahrain, they're all small places. So it's hard to know what to mean when you have a high rate of cases. But all those places have high levels of vaccine and high levels of disease, and I don't know what that means. They say it's because they have a lot of variants. In Uruguay, it's because of the it's because of the P1 variant. In the Maldives and the Seychelles, because the 617, now known as Delta. We'll see. Okay, so is there any contraindications to the vaccine for kids that have ITP? So ITP is a thing called immune thrombocytopenic purpura. And so this is a not uncommon disease in kids, mostly related to a reaction to a viral illness. And so what happens is the kids are fine, they come in, and I can remember this kid came in, he just had these just covered with bruises. Mom said, well, he's kind of an outdoorsy kid and do that. And I look at the bruises, and the bruises are in funny places for just a kid who's outdoors. He's got some on the chest. We don't usually get a lot of bruises on the chest from falls on the playground. You may get them on your arms or your legs. So a lot of bruises, and then you run a platelet count. So platelets are these tiny little things that are in the blood that help your blood to clot. And it really is an amazing system. So you talk about just amazing things that the body does. The clotting system is one of it. So what happens when you have a break in the skin, it sends out some chemicals, and the platelets say, I'm call to action. So that usually they're just floating around doing nothing in the system. And then what happens is when these chemicals come out, they somehow arrive at the scene of the crime. And what they do then is that they're sticky, and they stick to the areas trying to plug the hole. They then also set the framework for these protein strands that come across and help to heal a wound. So you've probably had a cut and have a scab on it. What the scab is platelets and red blood cells coming together with this fibrin, which is the protein, which holds us together, it makes a scab, and the scab stays around for a few days, and then it goes away. And when it goes away, you wind up maybe with a scar, but it's healed. I mean, imagine if we had other things that were so self-healing like that. But in any case, in kids with ITP, instead of having the normal amounts of 150,000 or greater platelets, they sometimes have 2,000 or 3,000. In this case, the granddaughter has 80 to 120,000. So that's probably more like a chronic ITP rather than that. There have been some concerns with platelets and especially platelet activation and the vaccines. There's no specific contraindication, but really this is something you should talk about with a specialist. So ITP is something that, as a pediatrician, you would occasionally see. I haven't seen much lately, but you would occasionally see, and I would always manage that with a specialist. So again, if she's got ITP, she almost certainly has a hematology specialist, and I would check with a specialist. All right, let's see. So we did have a death recently of a 54-year-old. So 54 is pretty young, and so what I worry about is that. So the good news is we've got a lot of vaccine. The vaccine is widely available. We're carefully looking at the side effects, and we see little things, but not seeing a lot. So there is this myocarditis thing. It appears to be relatively mild. There have been no deaths associated with it, and certainly we know that myocarditis is much more common with the disease than with the vaccine. This thing with the J&J, again, as they look for it, they're finding a few more cases, but still seems to be very rare, and again, much better than the clotting problems that you get with the disease. We're having a clinic this weekend. We're going to have both the Pfizer for people 12 and above, and the J&J for people who are 18 and above. It's going to be at the fairgrounds. It's going to be from 9 until 2. We're to the point where they're so fast at that clinic, we're not even doing appointments. Just show up anytime between 9 and 2. In addition, we've got our little team called the Tiger Team. They're going out to various events around the county. They're going to be at this event on the 5th. Then they're going to be at the Chainsaw Festival in Reedsport on Father's Day weekend. And then they're also going to be at some of the block party events at Too Shy. So lots of places to get the vaccine. So when we look at people who are vaccine hesitant, there are 4 groups of people that we're seeing are vaccine hesitant. Some of the people who are the procrastinators, as I said, people don't sign up for a colonoscopy on the first day that they can. It's like, oh, I'll wait until and I was guilty of that. I did get my colonoscopy until I was about 51. So, I waited a little bit of time. So that'll happen, and it's because people just haven't gotten around to it. It's not something they're looking forward to, and something they put it off. The story is, if you're one of them, please just come in and do it. You're going to have to do it at some point, and the sooner you do it, the better protection you'll get earlier on. we've had a couple of people who've gotten sick in the last week or two, and they said, darn, I was planning to get the vaccine at the end of the week, and then I got sick. Darn it, I wish I'd gotten it earlier. So I don't want you to be one of them. So come out and get it. Come out this weekend. It should be a fun time. It's supposed to be hot, but we'll do it. It's very quick, and you can get your choice of the Pfizer or the J&J. Or go to one of our Tiger Team events. Again, the goal would be to get people vaccinated. The goal of getting people vaccinated would be to just get rid of this. I mean, we have so much other public health stuff that we really should be focusing on that I'd really like to put COVID in the back. But right now, with the number of cases and the number of hospitalizations, that's hard to do. So we only had 22 hospitalizations last week. That was our highest ever. And Deschutes County is also seeing a very high number of hospitalizations. They actually sent out sort of a call like, hey, could anybody work in our ICU this weekend? What's happening in those places, they're seeing a lot of cases. They're also seeing other things that people wind up in the ICU with, post-surgery, trauma, accidents, and whatever, as well as the nurses are tired. I mean, many of these nurses been in the ICU have been working overtime, weekends, and whatever since last spring. And they're seeing a couple of things. One is, it's been a long time since they've had a vacation, and many of them saying, look, it's time for me to get a vacation. Can't blame them. The other thing that's happening is that in some places people are building up paid time off. So many offices, you get a day of paid time off every pay period. Well, if you've not had vacation in 26 pay periods, you might have a lot of vacation built up, and in many places you have to use it or lose it. So they're forced with the imperative that you could work basically for free or take a vacation. That's a pretty easy one for me to figure out. Is people then take the vacation? So there's a real worry that not only are we all tired of the masking and all this other stuff, that people who've been caring for this and have been in the front line are also getting tired. And so that's why I'd really like to put this behind us. And I think the way to do that is get vaccinated. Again, if we were about 80% vaccinated, we'd be down to 2 or 3 cases a day. We'd only have a few people in the hospital. It would be a really different view from where we're at now. So again, I think we're doing a good job, but we could do more. I'm asking you if you're in the group of people who haven't gotten vaccinated because you haven't gotten around to do it. The second group of people who haven't gotten vaccinated are people who really are busy and they can't find the time. So I talked with this fellow. He's working at a restaurant. He's working 6 days a week. It's like, really, 6 days a week? Yeah, we're closed on Monday, but I work all the other days. And my concern is that if I come to your clinic on a Saturday, not only do I have to take time off on Saturday, but then if I feel crummy on Sunday, I can't work. And really, the restaurant needs me and I need the money. And so that's another group. And we're really trying to work with that group to schedule around their schedules so that they can do that. But that's a real thing. We've got a lot of really, really, really hardworking people in town here, and they find it hard to find the day or so. Now, there are a lot of people who feel pretty crummy, especially after the second shot, and may not be able to work, especially a job like at a restaurant. And so I do feel for them. The third group of people who are looking for more data, we've got a lot of data. The docs in Douglas County are working with us. If you have questions, talk to your doctor. Your doctor, if you've got questions, hey, is this safe? What do you think about the research? I don't know about that Dr. Bob guy, but what do you think? Talk to your doctor for the people who are hesitant, worried about safety things. I think the more we see it, the more we see that these are really safe and effective. It looks like both Pfizer and Moderna are going to go for full FDA approval, not just the EUA approval, but the full approval this week. And then there are people who just don't want to talk about it. They just don't want the vaccine. They just don't want to talk about it. And my point in this, I'm always willing to talk. If you don't want to talk about it, I'm not going to force you. But I would hope that some of those people who don't want to talk about it might talk to a friend, a nurse, or someone else who you might trust, and to say, hey, what's going on? Is this just really a scam, or is this real? And then think about getting the vaccine. But again, the goal on all of this is to keep the amount of disease down, to prevent some of these really untimely deaths, and to help out our heroes in the hospital, especially those nurses who've been working in the ICU so hard over this last year. All right, that looks like it for questions. As always, I ask people to be safe and be kind, and we'll do this again on Friday. Thanks so much.